Well, let's hear the case.
All right, so Ms. Z, she's a 62-year-old pleasant lady. She came in with 2 months of progressive exertional dyspnea. She has no history, no cardiac history, no PCI, no history of CABG. She had a dobutamine stress echo for about 8 minutes and some EKG changes, but a new inferior lateral wall motion abnormality. So we proceeded with the angiogram, and as you see, a 99% mid-circ lesion. And in the same angiogram, we can kind of get a hint about the proximal left main disease. So we'll proceed with other views, and here it's more obvious, about 70% proximal left main. So we decided to proceed with imaging. We used IVUS, and we got an MLA of 5.6 millimeters square. At this point, apparently everyone would hold off and talk to surgery, right? So we proceeded with risk assessment. Syntax score was very low, was 12, and syntax 2 was 24.6 PCI, 20.6 for CABG. So we decided to proceed with the intervention. So a Samurai in LED, Marvel in the circ, proceeded with emerge pre-dilation, and then, a premier stent and post-dilation. This is the final result of the circ lesion. And then we used an NC for pre-dilation of the left main. And then we used the Promus Premier, deployed at 21 seconds at 20 ATM. And then again, we used the IVUS to assess the PCI. And then quickly, we decided to use the osteoflash balloon for the aortoatrial, for the aorto-osteal lesion. So as you see, the osteoflash balloon is pretty neat for the aorto-osteal lesions. So in multiple studies, I've shown to increase the MLA post PCI, and most importantly, it frays the edges of the stent to the aorta, so it helps re-engagement of the left main. And this is our final results. So, in conclusion, I would say ad-hoc left main PCI in patients with complex disease is reasonable, and IVUS should always be used in left main disease, and the osteoflash balloon can facilitate the vessel re-engagement. Thank you. Sure. Shall I start this?
The advantage of doing MC dilatation before left main stent, because you are putting other stents in and out, fine. So why we have to, before we put a left main stent?
Why would we use
the NC?
The emergency? I think this was used at discretion of the operator at that time, and we maybe for the proximal left main and NC would have made a better sense in this setting.
Yes, question.
We know that the osteal lesions are predominantly fibrotic, so some operators prefer to dilate the
use it.
osteal lesions with a non-compliant balloon first. I have a question regarding the type of stent used.
The Premier?
Premier, because there is a reported foreshortening with this type of balloon after post-dilatation. I think, if I remember the number, is around 15% foreshortening, longitudinal foreshortening after post-dilatation. So he did IVUS after the post-dilatation.
We did IVUS before post-dilation to just assess the opposition. And then after post-dilation with the osteoflash balloon, we did not use the IVUS now.
So the question about why using a non-compliant balloon is a little peculiar to me. Why would you not use it to prep the left main?
Every other was going in and out, and if you use it, what is the advantage of this is? If you are going to go and dilate it, and if you have to do it suboptimal, you can do it later. And I think what I would not like to use it, suppose you create a dissection and before you put a stent in, and that will make the things complicated.
Suppose you put a stent in and it's not expanded. Then what do you do?
Then use a
Then you can operate on the patient afterwards. So the whole point is to make sure that your left main stent expands maximally. So if
Okay.
you're gonna vessel prep, you better vessel prep before the stent goes in. So that would be the step to do, not to do.
I guess I'd like to back it up one step further and ask the question, why the left main at all? At almost 9 minutes on a pharmacologic stress study, I'm not sure what the time means in that. But the patient didn't have, sort of terrible symptoms, had 1 millimeter of upsloping ST segment depressions in the infralateral leads, and had a tight OM lesion.
Yep, that could be the
Sort of
culprit.
done, aren't you?
Yeah, but
I guess, the reason I'm asking the question, and I'm asking it knowing there is no correct answer, but I think we as interventionalists have to have, a very open mind about the changing ability, or the changed ability to manage even these critical lesions in patients using intensified medical therapies. It's not an us or them kind of debate here. And my guess is a left main that's got a 5.5 millimeter diameter lumen
5.6.
in a patient who presumably now will be asymptomatic. Now that may not turn out not to be true. That changes things. You take the patient off the table and you see the patient back in a month and they're doing everything they want to do. They're perfectly fine. The natural history of that kind of fibrotic, stable-looking left main 70% disease is not that hair-raising. But the complications associated with intervention with left main, although uncommon, are decidedly hair-raising. I think we have to be sanguine about the state of affairs here with this kind of disease.
Question for Dr. Parikh for my education. Suppose you did put a balloon and did not dilate, did not expand it. So what would be the next step to do in this osteal disease?
Then you figure out why it is. You can use a scoring balloon, a cutting balloon. If that doesn't work, you have atherectomy.
In an osteal lesion?
Yeah, absolutely.
Imaging would be the next step.
Imaging is the critical part of that.
Understand what-
But putting a stent in without knowing it can expand, especially in the left main, is equivalent to malpractice for us, right? You don't want to do that. So especially here, as Kirk is saying, and something that's potentially a borderline case, right? I mean, the culprit here was not the left main.
A lot of times, sometimes it has been shown that this kind of patient, the revascularization that fails, like with a bypass, because the left
Yes,
main was
I
not
was just
clear.
gonna make that comment. I think the flow down into the LED would have made, putting a lima graft problematic. But something that could help in sort of getting you an indication would be if you did an FFR,
Yes.
and there was, ischemia or,
So Kirk, if this
evidence of obstruction.
5.5 had an FFR value of 0.75, would you treat it?
I guess I wouldn't feel it was inappropriate to treat it. But again, I come back to looking at the totality here, not just chasing a number or a value. This patient, we didn't get all the detail, but presumably the patient's doing well, now has new symptom, et cetera. And I think we found the culprit and treated it nicely. I just raised the question of whether or not we are being sufficiently measured in our approach to this kind of disease 100% of the time. I think the answer is we could do a better
FFR
job.
will change for left main before and after dilating the OM?
I'm sorry, repeat that?
Is the FFR going to change
Oh, after you,
before and after dilating?
in the circumflex, it
When
will.
would like,
Yeah.
when would you like to do that FFR?
Yes, if you want to isolate the impact of the left main,
Yeah.
then you want to have, ideally, no disease in either the LAD or circumflex distribution. So the way to do that is to treat the OM lesion and measure the FFR across the left main.
And I think the consensus is that in this borderline case, I would definitely do FFR before doing the left main PCI. I would do FFR in both. After fixing the SARC, I'll put a FFR in the LAD, FFR in the SARC. If there is a doubt, it's a borderline IVAS results. And I was not sure, is that not a bypass candidate? I know that syntax score is pretty low. Just in
syntax is 12 and
Yeah. But,
syntax 2 is 20.
Is it a lot of comorbidities or is not? a
No, she
candidate?
does not have comorbidities.
So
but
Sergeant said
she
this-
was felt to be low risk for PCI as well on the same case.
The PCI was appropriate care for left main if it warranted treatment.
Mm-hmm.
We should go ahead.
Good.
Okay, thank
very
you.
much.
Nice case.
Nice enough.